Our experts will walk you through the science behind the egg and sperm freezing and how to get started. Feel free to submit your questions in the chat. We'll address them in Q&A at the end of our session today. So let's begin by looking at evolution of fertility preservations and why so many individuals are choosing to take control of their reproductive future. And now I'd like to hand it over to Dr. Bauer from IVFMD.
Very good. All right, thank you. Well, as Irina said, we're happy to be here for education and learning and all things fertility preservation. So I'm going to start out with a little bit of background. So as you can see from the timeline here, we were able to do things with sperm well before we were able to do things with eggs. And that's the interesting thing. So an oocyte, or an egg in the female body, is the largest single-celled cell that we have in our body, and therefore the water content is very high. And it took us a little bit of time to figure out how to safely freeze them so that they could actually be used again. So this gap from 1953, when the first human birth from a frozen sperm happened, to the gap where a first human birth from a frozen embryo occurred, was pretty large. And then again, another gap from the first human birth from a frozen egg. So, we've obviously made tons of advances, and it's very exciting where the field is now. Officially in 2012, the American Society for Reproductive Medicine lifted its what quote unquote experimental label on egg freezing. And since then, it has really been a mainstream process that occurs all over the country and all over the world. So very exciting stuff. Next slide, please. So you might ask, what is the value, or why should I freeze my eggs? So there are a bunch of reasons. Many of them are listed here, and all of them are valuable, whether you're not even sure you'd like to have a family or children, whether you just want to make sure you have a plan B, that's okay too. If you're not ready at all, if you're like probably all of the female physicians that are speaking with you tonight, maybe you had professional goals, like you were delaying your childbearing because you were in medical school or residency, or just focused on career, not ready to have a family. If you didn't have a partner yet, and then of course also for any sort of medical reason that might come up where you might be facing a treatment that could jeopardize your future fertility. So lots of reasons, all of them are valid. Pick your poison. Next slide. And just to give us perspective on why egg freezing is important, you have to look at the rates of infertility. Infertility is defined, depending on how old you are. Under 35 is defined as about 12 months of unprotected intercourse without a pregnancy, and over 35, that shortens to about 6 months. And about 1 in 3 women in their 40s will experience infertility. That's a lot. And 15% of women in their 30s, 7% of women, even in your 20s, can experience infertility. So it is not uncommon. When it comes to understanding if you are trying to get pregnant, the monthly chance of conceiving, if you look based on age, under 32 years old, you can have a 20 to 25% chance per month of getting pregnant, whereas if you're waiting until you're over 40, that chance goes down to about 5% per month. So there's a drastic change. And all of this is really based on the fact that we know that we are born, as women, we're born with however many eggs we will ever have. And over the course of our life, we lose them. And the rate at which that happens, of course, is different for every woman. And you can't tell by looking at someone or saying, oh, you're healthy, things must be okay. The process looks different for everyone. This graph here shows you with age on the bottom and follicle number. Follicles are what house eggs within the ovaries, show you how things change over the course, as you age. And then the other thing that is important to understand is that it's not just about getting pregnant. It's also about getting pregnant and staying pregnant, and getting pregnant with a healthy pregnancy and a healthy baby. And that's where this statistic, this forced statistic comes in, that after age 40, 50% of pregnancies will end in miscarriage. And the top reason why that happens is a genetic abnormality in the embryo. Because as we age, the ability of the egg, an aged egg, and the sperm to come together in the right way without making a mistake or recognizing that mistake goes down drastically. So you end up having a much larger chance of actually conceiving an embryo that becomes a fetus that may not be viable. And then, of course, not surprisingly, if we look at women 45 or older, the miscarriage rate goes, sky high, 70 to 90%. So really looking at a very high chance of miscarriage, all of which potentially can be, not avoided completely, but significantly reduced potentially if you have frozen eggs. So next slide. So in particular, one patient population that we certainly like to target is those that are cancer patients. So treatments like chemotherapy, radiation, and surgery can damage reproductive organs and affect hormone levels that can either lead to temporary or permanent infertility. And the reason for that is that chemotherapy tends to target actively dividing cells that are inappropriately dividing, like cancer cells. So chemotherapy does what it's supposed to do, but it also tends to significantly impact the ovaries. Your ovaries are constantly turning over cells. You're generating a follicle each month with your menstrual cycle. You're ovulating, then the ovary has to heal itself. So there's lots of cell turnover and lots of cell production that makes them particularly vulnerable to things like chemotherapy or radiation. So this particular patient population, it's really essential to preserve fertility before treatment because it offers hope for future parenthood. Next slide. So this is a general overview of fertility preservation options. And then after this, my colleagues are going to take over and sort of talk about each of these things in more detail. So I'll just briefly mention them. So obviously we have egg freezing, which, as we mentioned, is a well-established method for women to preserve their eggs for future use. We can also bank sperm and freeze sperm, and that's really the simplest and most widely used option for men. And then we get into ovarian tissue preservation, which is definitely an innovative method. There are some areas in the country where this is being done routinely, whereby if you have a woman that is much younger, who's not necessarily ovulating or even ovulating yet. So children that experience cancer diagnoses can sometimes have an actual portion of their ovary removed and preserved for later use. And then they can put that back for the purposes of preserving their fertility, which is wonderful. And then, of course, always in science and in our field, we have emerging techniques. So research is ongoing for new methods like testicular tissue freezing in prepubescent boys and different kinds of embryo cryopreservation techniques that may offer even more opportunities for our patients. So that's the overview. And again, I'll hand it over to my I'm not exactly sure who's next, but hand it over to my colleagues to get more into detail about these options.
Thank you very much, Dr. Bauer. Dr. Khan?
All right, so we're now going to talk more about egg freezing in some detail. So the benefit of egg freezing really stems from this age-related fertility decline. Whether you're delaying childbearing for social reasons or planning to take medications like chemotherapy that may damage the eggs inside of the ovaries, freezing your eggs at a younger age is a way to preserve your best quality eggs with the most reproductive potential, which can be really helpful if you run into fertility issues down the road or if you're starting your fertility journey when the risk of miscarriage is really high. The process of egg freezing involves taking injectable medications, about 2 to 3 injections per day for on average of 11 days. When we see that we've gotten as many eggs as we can to grow, you have an egg retrieval procedure, which is under anesthesia, which is IV sedation, and the eggs go right from the ovary and our specialized ultrasound machine into the IVF lab, which is always attached to the operating room. and that's where they're frozen. Next slide. Vitrification is the process of flash freezing the eggs in a glass-like state in liquid nitrogen. The eggs are incredibly stable for long periods of time and have really great survival rates. This is nothing like your kitchen freezer. It's really the coldest of the cold. Next slide. So as we mentioned previously, age is the most important indicator for natural fertility and for fertility treatment success. Women are born with all the eggs that they're ever going to have in their life, as mentioned, and we're born with 1 to 2 million eggs. By the time we hit puberty, we have 300,000 to 500,000 of them, and they're stored in a vault inside of the ovary. And every month, a small grouping of eggs are released from the vault, and they have the potential to be stimulated by the brain to grow and ovulate. That signal from the brain is just strong enough to get one of those eggs to grow and release, and the rest of those eggs just die off, and that's part of the natural age-related fertility decline, that we're just constantly losing eggs. The rate that we lose our eggs is different from person to person, and that's genetically predetermined, as we discussed. But when we run out of eggs, we stop getting periods, and that is called menopause. The number of eggs that we have available to stimulate each month really means nothing when it comes to natural fertility, but it means everything when it comes to freezing your eggs. And so we are really manipulating a natural process here. We're just trying to get all of those eggs that were released from the vault to grow and rescue them from their fate of otherwise dying. So when you start this process, it really starts with an assessment of your ovarian reserve, and that's how we set expectations for how many eggs we might get. The other part of this age-related fertility decline is the quality decline of the eggs. And because these eggs have been inside of you since the day that you were born, again, the DNA inside of them gets a little sticky with time, which means the older they are, the more likely they are to contribute an abnormal amount of DNA to a pregnancy and therefore increase miscarriage and infertility. So again, when you're freezing your eggs, they say the same quality as the age at which you froze them, which is the best they'll ever be. Next slide. Freezing technology has advanced so much that the survival and fertilization rates of these eggs is, and embryo quality and the live birth rates are the same no matter if the eggs were frozen for a few months or for many, many years. Again, they stay very stable as they're frozen. Next slide. And I think this is a really important slide because it shows that not every egg is destined to become a baby. Not every egg will survive the thaw. Not every thawed egg will fertilize. And not every fertilized egg will become an embryo and then implant to become a healthy pregnancy. So the more eggs you freeze, the higher the chance that a pregnancy will result from those eggs. Next slide. The number of eggs that you should freeze to have the best chance of pregnancy success or to meet your family size goals really depends on the age at which you're freezing them. So if you're less than 35, 15 eggs will get you about an 85% chance of a live birth, whereas 15 eggs at age 37 may give you a 70% chance of a live birth. And at age 40, 15 eggs may give you about a 50% chance of a live birth. And so the younger you are, when you do an egg freezing cycle, the more eggs that you'll likely get from a single round of stimulation, and the higher the chance those eggs will result in a live birth. It's not impossible to have a baby if you freeze your eggs later, but the older you are, the more likely you'll have to do multiple cycles to get the number of eggs that you want for a reasonable probability of a live birth. And I'll pass this over to the next doc.
I believe that's me. So I'm just going to go over what a typical egg freezing cycle looks like and what the timeline is. So as with any doctor's visit, when you present initially, we're going to go over your medical history and your family history. We're going to discuss what the egg freezing process entails and what sort of testing we need before we actually start cycling, before you actually start the egg freezing cycle. So there are a bunch of tests that we need to get, and one of them is to figure out what your ovarian function is, more specifically to figure out what your ovarian reserve is, basically how many eggs do you have. And we do that two ways. We get a hormone called your anti-Mullerian hormone, which allows us to class you as either having an average ovarian reserve or an above average ovarian reserve or a below average ovarian reserve. The other way we do that is by doing an ultrasound to get what we call your antral follicle count, which basically gives us a snapshot of how many of those follicles you're producing per month. Some of the other tests we may do is something called genetic carrier testing. This is just to see if you are a carrier of any genetic conditions that could potentially be passed down to any offspring. And then we want to figure out, we do a standard infectious disease panel testing for conditions such as HIV, hepatitis B and C, gonorrhea, chlamydia. And then we also want to make sure you are up to date on your general healthcare screening. So that would include ensuring that you've had a recent pap smear, and if that pap smear was abnormal, you've had that appropriate follow-up. And then breast cancer screening as well, if that's relevant. Now, once we've gotten all those tests and we've gotten the answer, really especially from your ovarian reserve, that then allows us to come up with an appropriate egg freezing protocol for you. Once that's done, we can then, you can actually start the cycle. Typically, most of the cycles we do are usually with the start of your menstrual period. You would come into the clinic, we'll do an ultrasound, we'll do blood work, making sure everything looks fine in that regard, and then you start the injections. With a typical egg freezing cycle, you're taking these injections daily, anywhere between 10 to 12 to 14 days. During that period, you're coming into the clinic ever so often for blood work, for ultrasound, so that we can make sure you're responding to those medications appropriately, and we can adjust the doses of your medications as needed. After that length of time, once those follicles have gotten to the size where we think they should contain an egg that we can then retrieve, you get another medication called a trigger shot, and about 36 hours after that trigger shot, we then undergo the egg retrieval procedure. Next slide, please. So the egg retrieval procedure, like Dr. Khan mentioned, is a minor surgical procedure. So we give you anesthesia, you go to sleep, and then, but you're not intubated. And then once you're asleep, we use an ultrasound probe that has a needle attached to it. That needle goes through the wall of the vagina, and that's how we access the follicles within the ovaries. The needle drains the fluid within those ovaries. That fluid gets given to an embryologist, who then looks under the microscope and tells us whether or not there are eggs in that fluid that we've collected. That egg retrieval procedure lasts anywhere between 10 to 15 minutes, depending on how many eggs and how many follicles you have. Once the procedure is over, you go to the recovery room where you recover for anywhere between 30 minutes to an hour, and then you go home. We typically would recommend that you should take at least the day of the egg retrieval off, and possibly the following day as well. Next slide, please. So there are some risks of the egg with the stimulation process, where we give you the medications and also the egg retrieval itself. So there is a risk of something called ovarian hyperstimulation. This is something that can happen during the time of the stimulation, but more typically happens after the retrieval. Basically, your ovaries produce a bunch of fluid that accumulates in your pelvis and your abdomen. It can make you feel bloated and nauseous. The risk of becoming hyperstimulated really is a function of how many follicles you have. The more follicles you have, the more your risk of becoming hyperstimulated. However, the way we manage the cycles in terms of the dosage of the medications, the length of the medications, helps to mitigate that risk. The other risk is that sometimes, although we try and make sure that you are an appropriate candidate for this procedure based off of your ovarian reserve markers, sometimes some people don't respond as you might expect them to, in which case we may actually have to cancel the cycle because of poor response. Next slide, please. So what happens when you're ready to use the eggs? So the one thing I always tell my patients is that just because you freeze your eggs doesn't mean that this is the method that you have to use to become pregnant. But if and when you're ready to build your family, and this is the method that we are using to build your family, what happens is that, you go back into the doctor wherever your eggs are frozen. You may go over your family building goals again. Your partner this time would also need to come in to be evaluated in terms of his general health, as well as his sperm parameters. We would want to make sure that your uterine cavity is a hospitable enough environment for an embryo transfer. We'll make sure all the testing that we did prior is also up to date. Once all of that is done, the next step is actually to fertilize the sperm with your partner's sperm. And then once that's done, or in tandem, we'll also be preparing your uterus to receive that embryo. And once your uterus is ready to receive that embryo is then transferred. And I believe that was the end of my slides.
Thank you very much, Dr. Kiara. Dr. Patel?
Thank you so much. So what happens to your eggs if you never choose to use them? You have a few choices. The first choice would be obviously to discard those eggs, very much like you're naturally ovulating and undergoing programmed cell death every month. If you so chose, using our guidelines in place, you can actually donate these eggs to somebody else who's on their fertility journey, or to somebody else who can use them. You can also donate them to science. These are your eggs. Whatever you've written and chosen to do with your eggs is how they will be treated. And so eggs will never be inseminated by any sperm source without any form of written consent. Once the eggs are vitrified, they cannot be donated anonymously. They would be donated kind of in a known fashion. But probably the most important thing to remember with your eggs, if you choose not to use them, is that this is completely your choice. Next slide. So let's switch gears and let's just talk a little bit about sperm banking. This can be done for male patients undergoing cancer therapy, but also those undergoing elective fertility preservation. If we talk about cancer therapy first, it's interesting to note that cancer survivors shared that 70% wanted to protect their fertility, but only 24% actually banked sperm. Banking of sperm is really a very efficient process in most cases. How many samples to preserve will kind of depend upon what your goals are, the type of cancer, and then ultimately the number of children you'd like to have and the type of cancer therapy you're going to undergo. There's certain cancers like leukemia that are going to require more vials of sperm than something like prostate cancer. In general, though, you would assume that per envisioned child, maybe 2 to 3 vials of sperm. And that would give you options down the road should you consider intrauterine insemination or in vitro fertilization to father a pregnancy. How many sperm can be frozen? Anything from 1, but on average, it's 5 to 20 million is appropriate per vial that is frozen. How is sperm collection done? Usually it's done in a clinic setting through masturbation. Sometimes if needed, home collection kits are also available. If there's a blockage, sperm can be obtained surgically via biopsy. And in some cases, if there are issues with retrograde ejaculation or spinal cord injury, either harvesting the sperm from the bladder or electroejaculation can be used to freeze the sperm. The sperm is usually frozen by mixing it with cryoprotectants that are liquids that will protect the sperm against damage when you're freezing the sperm and then thawing the sperm. And interestingly enough, the sperm can be frozen for many years. The longest reported pregnancy is over 21 years, resulting in a pregnancy. So sperm banking is definitely an option. Electively, sperm banking, especially for men younger than the age of 40, can be protective. As we know, there is a very subtle increased risk in autosomal dominant diseases, autism, and even mental health disorders with the aging male or the aging sperm. Next slide. Another option, going back to the female patient, is ovarian tissue preservation. This is usually a procedure that is used to freeze the tissues that contain resting eggs from the cortex of the ovary. This is usually done if immediately the ovary needs to be removed or in a very young woman before puberty or a young child before puberty. In this procedure, the doctors will take slices of ovarian tissue from the ovaries and then they'll freeze them. Once you've undergone cancer treatment and you are now a survivor, those slices of ovarian tissue can be placed back into the abdomen. It can be placed near where the original ovary is, or it can be placed in a different location. If you should place the ovarian tissue right near the fallopian tube or at the site of the old ovary, interestingly enough, after about 4 to 9 months, you'll start to see follicles developing, and some patients have been reported to spontaneously conceive. If not, a doctor can use medications, very much like all of my colleagues have shared, injections to help produce multiple eggs. Those eggs can be harvested, embryos can be created, and then transferred back into the uterine cavity. Over the last 10 years, about 24 births have been reported with this technique. So it's possible, but it's still very experimental and something that is done in a very rare case where the other options presented to this point are not better options to be utilized. Because one of the disadvantages to this would be if there are cancer cells in the ovary and now we transplant that ovarian tissue back into the abdomen, it can put the patient back at risk. Next slide. The most important thing in this entire journey that everyone's reviewed is the emotional and psychological considerations. There's a lot of uncertainty of your fertility after cancer therapy, or of really the uncertainty of your fertility if you're choosing to delay your fertility. And this can make it very stressful. I think seeking out care with a reproductive endocrinologist to really become educated, to understand the risks, benefits, alternatives, to all the options that exist for you can be reassuring. Also, I think the opportunity to know that you have the choice to preserve your fertility in this day and age really gives individuals emotional relief. It empowers them and gives them back their reproductive autonomy. Whether you choose to preserve your fertility or not, it's wonderful to know that you've got resources to become educated, resources to support you, and the option to preserve your fertility exists. Wonderful. Next slide. Thank you so very much. And back to you, Irina.
Thank you very much. I think we covered a lot of information today, and I know it's a lot, but I'm really thankful for 4 of you to joining this panel today. And we now will open the floor to our patients to ask any questions that might have. Perfect. And you're welcome to type your questions in the chat box, and I'll address them to the physician. So the first question that we receive is, and I will open to all of you to answer this question, and please feel free to step in to comment on that. I've read that egg quality is more important than egg quantity. If I freeze 10 eggs at 35, does that give me the same chance of pregnancy as freezing 10 eggs at 30? How do you determine if my eggs are good enough? And I'm not sure who wants to start this conversation, but we'll open the floor.
I can sort of start. You might have to repeat some of the question, but I think an important factor to understand. So certainly quality is very important, but quantity is also important. So it's sort of a complex issue, because we know that the process of being able to use the 10 eggs that you freeze inevitably involves loss at every step along the way, that like we talked about. And sometimes that can be up to 30 or 50%. And so if you're not starting out with a good number, the likelihood that you'll make it to the finish line becomes lower. And that likelihood goes down even further, I would say, the older the eggs are, right? So I guess would I rather have 10 eggs at 30 than 10 eggs at 35? Yes, but I would also recommend the older you are, the more eggs that you are able to freeze, the better. And there are many tools out there that can help patients understand, gee, for my age category, what is the likelihood that I could have a child from those numbers, from those numbers of eggs? And you have to feel, it's a very personal decision. It's a very personal feeling. You have to be okay. Some people are saying, okay, I feel fine with about a 50% chance that I could have a child from these eggs. And some people say, I want to max it out. I want to get, 80, 90% chance that I could have a child from these eggs. And based on your age, that's a different number, based on the best data that we have. So I always say to my patients, like, today is better than tomorrow, and yesterday was better than today, but we do what we can, right? So hopefully that partially answers the question.
Excellent, thank you. Anybody else would like to comment on this question?
I can comment. So I think part of this is also like, when does this age-related fertility decline set in? And at no point does the quality decline just like fall off a cliff. Your egg quality is never going to fall off a cliff. It's more of a gradual decline that starts at age 35 and it's sort of accelerated from there. And I think the difference in egg quality between age 30 and 35 is not that huge, but comparing that from 35 to 40, that is really big. And so, I think you have a little bit more wiggle room of when you are less than 35, but after 35, there's a lot less wiggle room, and it's really like every month counts to get those eggs out to preserve them.
Excellent, thank you. All right, so I think we'll move on to the next question. What if my body doesn't respond well to fertility medication used for egg freezing? Other cases where a cycle has to be canceled due to the poor response?
Sure, I can start with this question and then appreciate everyone else's input. So I think typically, as was already mentioned, a lot of testing is done in planning for your egg freezing cycle. So taking a look at your AMH, taking a look at your antral follicle count, taking a look at your FSH, LH, and estrogen really helps your physician to determine what's the best protocol. Sometimes, though, as you start into stimulation, we'll find that you're not responding as well as you should be. If you're not, and it appears we're not going to get a nice cohort of eggs, we may choose to cancel. If that's the case, when you meet back with your reproductive endocrinologist, you'll kind of look at a number of different protocols. There's so many protocols available. You can look at clomiphene protocols or letrozole protocols. You can look at a combination of oral and injectable medications. Sometimes the reason you didn't respond was maybe there's an imbalance between your FSH and LH, and being able to kind of fine tune the proportion of the medications you're taking is helpful. Sometimes we need to kind of program your body differently. We may treat you ahead of time with the medication in the cycle before, whether it's an adjunctive medication. Sometimes we'll look at different approaches in the cycle, whether we're using Lupron or an antagonist, pre-treatment or growth hormone. So your team here and your personal reproductive endocrinologist is going to have lots of different protocols available to help you in finding what works best for you so you respond well. I hope that answers the question.
Thank you.
And just to add to that, it's not uncommon where from 1 month or to a subsequent month, the response to a different, like one protocol to the other could be quite, maybe not drastically different, but significantly different than the prior cycle as well.
Thank you. And our next question is, I understand that freezing embryos has a higher success rate than freezing eggs. Why is that? And should I consider freezing some eggs now instead of freezing only unfertilized eggs?
I can start with that one. So as we mentioned in the talk, not every egg is destined to become a baby. Not every egg will fertilize, not every fertilized egg will become an embryo, and not every embryo is going to implant. And so what I tell my patients is that eggs have a lot of hoops to jump through. And when you're freezing eggs, there's a lot of variables that we just don't know. We don't know who the sperm source is. We don't know how many eggs are going to fertilize. We don't know the transition into, or the conversion to the embryo. And so you got to freeze a lot more to try and guarantee a live birth. Whereas when you freeze embryos, we have really good data to tell us that, one chromosomally normal embryo gives you about a 65% chance of a live birth. So you can have a little bit more confidence about what you have in the freezer, because those eggs have already jumped through all those hoops. They've fertilized, they've grown out to become embryos, and you're freezing them at the embryo stage. The downside to embryo freezing is that you have less reproductive freedom. You can't unmix egg and sperm. And so it's really a personal decision of whether you decide to freeze eggs or embryos. And I have plenty of patients who'll do like one cycle of egg freezing, one cycle of embryo creation, or if they're a really high responder and are making lots of eggs, they'll do freeze half of those eggs as eggs and then commit the other half to freezing embryos with a partner or donor sperm.
Excellent. Thank you. Anybody would like to comment on the question? Okay. So then we can dive into the next questions. There are a lot of fantastic questions today. If I freeze my eggs at 30, but don't use them until I'm 42, what are my actual chances of having a baby? Do eggs frozen at the younger age guarantee success later on?
I can take that one.
Perfect.
So there's nothing really that we do or offer that guarantees success. However, freezing your eggs at an earlier age definitely is a higher chance of success than if you were to freeze them at an older age. Now, what determines the reproductive potential is the age at which those eggs were frozen and not the age at which they were then used. So eggs that were frozen at 42, well, if you were ready to have your children at the age of 42, your chances of pregnancy are dependent on the quality of the age, so the quality of the eggs at which you froze them, which at age 30 presumably would be a pretty good chance, and not at your age of 42.
Okay. Excellent. Anyone else would like to join on that discussion?
I think maybe one other point to mention is that certainly there are inherent risks to a pregnancy, like complications of pregnancy, like problems with your blood pressure, or problems with diabetes, or problems growing the baby, or that sort of thing, that are higher when you're older compared to when you're younger. So while don't get me wrong, obviously the age of the egg and the quality of the egg that will ultimately become the embryo is really important, and the younger that egg is, the better it will do. But it's also in understanding your chances of having a healthy baby, it's also important to consider how old you are when you are pregnant, because inherently there may be more risks in a woman that is older, over 37, over 40, something like that, compared to being younger as well. And that risk is a separate risk that plays into the whole equation. So I think that's also an important aspect for people to understand as well.
Excellent. Thank you very much. I have another question. So if I freeze my egg in one clinic, but I move to another state or a country, can I transfer my frozen egg to a different clinic later on?
I can take this question. So interestingly enough, when it comes to embryos, different clinics will have different policies with embryos, and embryos are not usually transferable between clinics from different kind of parent families, so to speak. Eggs, interestingly enough, most clinics and most providers are a lot more forgiving because of the fact we know women are protecting their fertility, men are protecting their fertility, and that plans will change. So most clinics, not all clinics, but most clinics will accept eggs from a different clinic. You do want to check ahead of time to be sure. But our clinic, for example, we do accept eggs from other clinics around the country. You can ship your eggs to a different country. Typically, they're not going to go the traditional route because we don't want them to get stuck in customs. You'll use a private courier who would transfer them from the US to an international country, but it can be done. That's a great question.
Thank you. Anyone else would like to comment on that question? No? Okay, excellent. So our next question is, if I freeze my embryos with my partner and we separate later on, who has the legal rights over those embryos? It's a great question.
It is. I can start with this one. That's definitely a difficult scenario to be in. And the thing that I like to remind patients, and why egg freezing, if advised by your doctor, is definitely advantageous, no matter what kind of relationship you're in, because things happen, is that when you have embryos, those embryos are property of both of the individual contributors, right? And so it can get a little bit dicey if something happens, or if they split or divorce. Typically, prior to creating the embryos, when you're signing your consent forms and all of that, you need to designate what would happen to those embryos if you and your partner were to split. And certainly, options include discarding them or giving them to one or the other. There have definitely been some legal cases in the news regarding this, and sometimes these cases go to trial, and a judge makes a determination of that based on the scenario. So there are a lot of different options, and so typically we have you designate what you would like to happen ahead of time, but that doesn't necessarily mean that can't change later on, I guess, is the takeaway message.
Excellent. Any other comments on the question, legal question? I know it's a very tricky question. And we have a legal department in our network as well to be able to assist with those types of questions as well if needed. Excellent. So the next questions is on, I guess, ovarian reserve. So the patient is 34 years old, and they're considering freezing the eggs, but the AMH level is still high. The question is, should I wait another year or two, or it's better to freeze eggs sooner rather than later?
I can start with that one. So it's important to remember that the ovarian reserve, or AMH level, which is really the biomarker of your ovarian reserve, does not tell us anything about the quality of those eggs. And so it's important not to be too reassured by a really good AMH, because a lot of poor quality eggs does not give you the end result that you want. And so I think when to freeze your eggs should not be based on the markers of ovarian reserve that you have, but more on your age.
Anyone else would like to comment?
And just to quickly add is that we don't have any way of objectively testing what your egg quality is. We can only make these assumptions based off of your age, and younger is always better.
Excellent. Thank you very much. There's fantastic discussion happening tonight. I'm very happy to see all the questions. So the next question is, my mother went through menopause early. Should I assume I'll have fertility issues too? How much does my family history really matter when deciding whether to freeze my eggs?
It's a great question, and I'll try and start off with answering this one. So I do think there's a correlation between a woman's reproductive career and her maternal line, specifically her mom and her grandmother. So if your mom did have a shortened reproductive career, the thought would be you might be at risk for that. It's not the only variable. It would depend upon, was it just genetics for your mom? Was there potentially other issues at hand, whether it be reproductive toxins, whether it be surgery, that could have contributed to that early loss of ovarian reserve? However, if your mom does have a history of a very shortened reproductive career, I think it's probably really prudent to see your reproductive endocrinologist, assess your fertility, and really take advantage of the opportunity to preserve your fertility so you don't have regret if you're going to follow those same lines. Great question.
Thank you very much. Any other comments from physicians? And I see our last question for tonight. I feel a lot of pressure to freeze my eggs because of the age and career, but I'm not sure if this is the right decision for me. How do I know if this is something that I really should do?
I can answer that one.
Thank you.
I always say this. This is something people always ask when to see a reproductive endocrinologist, and my answer is if you have any questions at all about your fertility. And a lot of the fear and the pressure really just comes from the unknown and the uncertainty. And don't underestimate how even just the power of having information can help calm by just providing you clarity and directions and allowing you to make informed decisions. So that really, I think, just the first step, if you are able to, is just seeing a reproductive endocrinologist, even it's just to have a chat about what fertility entails, where there may be issues with it, and what options are available to you.
Excellent.
I'll just add something to that, in that if you freeze your eggs, it doesn't mean that you have to use them. And the goal would be that you don't. I mean, when you buy an insurance policy, the hope is that you never have a situation where you have to use them. And the real, I guess, the goal or the benefit of the egg freezing is that it gives you options so that if you need them, you have you have plan B, you have something to fall back on. And if you don't need them for baby number 1, then maybe you need them for baby number 2 or number 3. And again, this just provides you more options to, make the family of your dreams.
Thank you. Wonderful. Any other comments from physicians? Thank you once again for your time, for joining us today for this very fruitful and meaningful discussion. I really appreciate it, and I'm sure our patients as well. This webinar is recorded, and for those patients who are unable to listen to a live webinar, they all will receive a recorded version. So thank you once again for joining, and I hope to see you next month on our next webinar. Thank you.
Thank you very much.
Thank you. Bye-bye.
Goodbye.
Bye. Thank you.